And we're kicking off with a plenary by a very good friend of mine, a very distinguished psychiatric researcher from Paris, Professor Bruno Etain from the Université Paris Diderot. Bruno is a real-world expert on childhood trauma and bipolar disorder, and he's going to lecture us about when childhood trauma shapes the mind, brain and body in bipolar disorder, and he's going to review current knowledge and impact on management. We'll have about 10 minutes of questions at the end. So without further ado, it just behoves me to say bienvenue, Bruno, welcome, and we're very grateful, and hopefully sometime in the next near future we'll be able to welcome you to London directly. We'll now go to Bruno's lecture. Thank you very much.
Good morning, everybody. I'm very happy to participate to this symposium. My name is Bruno Etain. I'm professor of psychiatry at the University of Paris in France, and also a visiting researcher at the Center for Affective Disorders in the IOPPN. My talk will be today about how childhood maltreatment can shape body, mind, and brain in bipolar disorders. Here are my disclosures. I have nothing really relevant to disclose in relation to this talk because my research are mainly funded by the University of Paris, the Hospital of Paris, and some French agencies for research. I will start with a very brief introduction about how childhood maltreatment can modify body, mind, and brain in the general population. And we know that childhood maltreatment is very frequent in the general population, and the prevalence rates are described, for example, in several World Health Organization reports. It has been reported that sexual abuse is present in between 6 to 20% of females and between 5 to 10% of males. Physical abuse is much more prevalent in the general population because between 1/4 to 1/2 of the general population reports having been exposed to physical abuse during childhood. This whole report doesn't include the fact of being bullied at school, which is reported in some UNESCO reports, and it is estimated that 1/3 of people between the age of 11 to 13 years old have been bullied at school. This form of maltreatment is developing quite rapidly, and especially being bullied at school plus being bullied in the social medias is very prevalent in the general population and in the adolescent population especially. We have quite a lot of studies showing in the general population that childhood maltreatment increase the risk of developing psychiatric disorders in adulthood. This is just an example among others from the NISARC, which is a US general population sample, and looking at the association between childhood physical abuse and different kinds of psychiatric disorders. As you can see on these slides, when people describe having been exposed to physical abuse during childhood, they report also more frequently than the non-exposed population several kinds of psychiatric disorders, including anxiety disorders, mood disorder, psychotic disorders, suicide attempts, substance use disorder, and so on. And when we look at the top 4 associated disorders with childhood physical abuse, we find first ADHD, second suicide attempt, then PTSD, and interestingly, bipolar disorders. We also know from the general population that maltreatment and childhood maltreatment increase the risk of having a poor physical health in the adulthood. This is just an example among other, because this is a meta-analysis published 3 years ago showing that when people have been exposed to childhood maltreatment, they report in adulthood a higher rate of obesity, for example, diabetes, cardiovascular diseases, cancer, or other types of physical health problems. So it means that childhood maltreatment not only increases the risk of presenting psychiatric disorder in the adulthood, but also presenting with several physical conditions that are associated to early life stress. And the last slide of this very short summary is the fact that childhood maltreatment modified the functioning and the connectivity within the brain. So this is a study in a sample of young adults with or without childhood maltreatment. And as you can see on this slide showing the connection between, for example, the left anterior cingulate or the right anterior insula to other brain structure, that there are some very deep modification of the connectivity of this brain region to the other brain region of the brain in those having been exposed to childhood maltreatment as compared to those without. So it means that we can observe in those with childhood trauma psychiatric disorder, physical health problem, but also strong problem in the structure or the connectivity within the brain. I will now move to childhood maltreatment and the impact on body, mind, and brain individual with bipolar disorders. And as you all know, bipolar disorder is highly heritable, meaning that the part of the phenotypic variance that is linked to genetic determinant is very high, with a heritability about 60%. But this study in the sample of 9 million subjects in Sweden also demonstrate again that there is also the contribution of environmental determinants in the vulnerability to BD or to schizophrenia, as shown on this slide. And we can identify several different types of stressors that can occur during the lifespan that increase the risk of developing psychiatric disorder in adulthood. This can be very early stressor in life, for example, during pregnancy with maternal infection, but this can be perinatal events such as hypoxia or problems immediately after birth. Later on, it can be childhood trauma or the exposure to maternal stress. And later, it can be, for example, migration, living in a urban environment, or being exposed to cannabis use in the adolescence. And all these environmental determinants are known to increase the risk, for example, of schizophrenia or depression or anxiety disorders. So before moving specifically to bipolar disorder, I will make just a step beyond to describe very briefly some clinical samples we are using and studying in Paris, and just to have a short slide on the childhood trauma questionnaire, which I will refer to very often in this talk. So in Paris, we are using mainly two different clinical samples. The first one, which I will call the genetic sample, is composed of 700 individuals with bipolar disorder, euthymic at assessment, assessed with the diagnostic interview for genetic study, and also assessed for childhood trauma with the CTQ and some dimension of psychopathology, and all of them having a biobank with DNA and RNA and so on. This genetic sample has no follow-up data and has been included in 3 centers in France. And during my talk, I will use this DNA picto when referring to this genetic sample. The second sample I will use during this talk is called the phase BD sample, which is a sample of more than 3,000 individuals with BD, euthymic at baseline, assessed with the SCID, having a clinical assessment with the CTQ, some dimension of psychopathology, being followed up 2 to 3 years, and being recruited in 12 centers in France. Since this sample has been included as part as the network set up by the Fondation Fondamentale, I will indicate on my slide this picto when I'm referring to this sample. And the second step beyond is to briefly present the childhood trauma questionnaire for those in the audience who are not familiar with this type of assessment. So it's a validated retrospective assessment of the exposure to childhood maltreatment. It's a self-report with 28 items, and what is interesting in the CTQ is the fact that it assesses a whole level of childhood trauma, but also some subcomponents that are emotional abuse, emotional neglect, physical neglect and physical abuse, and also sexual abuse. So it means that using, for example, the CTQ is important to disentangle the different subtypes of trauma an individual have been exposed to. So my first part of this talk will be is childhood maltreatment associated with bipolar disorder, and as you can guess, the answer is obviously yes. But the studies in this field are very recent because, for example, Georgina Ozang and Ellen Fisher in the IOP have reviewed the evidence for the association between childhood maltreatment and bipolar disorder in 2010, and it shows that at this time only 3 studies using a very careful methodological design, a validated approach, and so on had been published so far. So we had 3 studies, one from Grandin, the second from Nerin, and one from our group, being published in 2010. So in the same year, we have published a case control study using the CTQ in a sample of patients with BD as compared with healthy control. And we have found first that the level of CTQ was significantly higher in patients as compared to control, illustrating the fact that they have been exposed to more traumatic events during childhood. And when you look in the table as the different prevalence of the trauma subtypes, you can see that all types of emotional trauma and physical trauma are overrepresented in patients with BD as compared to control, with only a borderline significant association with sexual abuse. And the highest significance level was seen with emotional abuse being much more severe in patients with BD as compared to control. What we also find in this study is the fact that patients with BD also reported having been exposed to multiple forms of trauma as compared to individuals without bipolar disorder. This means that in the general population, the level of exposure is lower, whereas in the population of patients with BD, the level of exposure is much higher and much multiple, meaning that they report when having a BD several types of trauma, meaning emotional abuse plus physical abuse plus sexual abuse. So trauma are more frequent, more severe, and more diverse in the population of bipolar patients as compared to control. We now have an excellent meta-analysis being published in the British Journal of Psychiatry 3 years ago, including 19 studies, which are case control or epidemiological studies. And this meta-analysis illustrates the fact that all types of abuse and neglect, with the exception of parental loss, have been reported as being much more severe and frequent in patients with bipolar disorders as compared to the healthy population. And as you can see, the odds ratio, the highest odds ratio is reported for emotional abuse, because this odds ratio is above 4, whereas the association with physical abuse, sexual abuse, and different type of neglect are probably of a lower magnitude, because they led to an odds ratio which is more or less between 2 or 3. So it means here again that probably all types of trauma are important in bipolar disorder, but probably emotional abuse play a specific and a more prominent role in the vulnerability to BD. I will then move to a second very important part of this issue about childhood maltreatment and BD, which is the fact that childhood maltreatment induces multiple penalties in BD. So it means that it increased the clinical expression in terms of severity or instability. It increased the level of comorbidity. It increased the duration of untreated illness, and it decreased the response to medication as lithium. So not only bipolar disorder is predisposing individuals to suffer from this type of disease, but also it leads to a more severe and complex phenotype of the disorders. So first, with some colleagues in the University of Oslo, we have assessed quite large samples of patients with bipolar disorder, so from France and Norway, with the same clinical assessment and using the CTQ. And we found in this study that when patients with BD have been exposed to more types of abuse, so meaning emotional plus physical plus sexual abuse, they present with a lower age at onset, more suicide attempt, more cannabis misuse, but also a more unstable evolution of the disorder, with more depressive episodes, more hypomanic episodes, and more rapid cycling. So it means that childhood trauma increased the severity and the complexity of BD. This has been confirmed in this large meta-analysis, including 30 studies about the association between childhood maltreatment and clinical outcomes in bipolar disorders. And as you can see on the graph, all the odds ratio for all the clinical outcomes are above 2, for some of them above 3, and all the clinical outcomes that has been explored in this meta-analysis have been associated to childhood trauma. So it means that the level of manic severity, of depressive severity, of psychotic severity are associated with childhood trauma. All the different types of comorbidity with PTSD, with anxiety disorders, substance use disorders, suicide attempt are increased in presence of childhood trauma. Patients with childhood trauma have an early age at onset, more frequent episode, and more unstable outcomes of the disorder, for example, as with rapid cycling. So it means that childhood trauma deeply modified the clinical expression of the disorder, and as such can be proposed as what we call a disease modifier, meaning that not only it predisposed to bipolar disorder, but also to a more clinical, complex, severe outcome. Probably one of the most well replicated results is the association between childhood trauma and the age at onset of bipolar disorders. And this is a figure extracted from the same sample collected in France and Norway, showing that when the patient have been exposed to more abuse subtypes, they have a significant decrease in the age at onset. So the more the trauma is present, the lower is the age at onset. And this has been replicated in many studies in Europe, in the US sample, and for example, also in Australian samples. Another interesting association between childhood trauma in BD is the fact that when the individual has been exposed to childhood trauma, they also report a longer duration of untreated bipolar disorder. This is a study published by Leverish and Post showing two samples of patients with bipolar disorder, one having been exposed to childhood physical abuse and the other one having not exposed to such an early life stress. And as you can see on the upper part of the graph, when the patient has been exposed to childhood physical abuse, they start their bipolar disorder at the age of 15, and then they have to wait 13 years to receive a first treatment for their bipolar disorder. Whereas this duration of untreated bipolar disorder is only, I would say, 8 years in those not being abused. So it means that in presence of childhood trauma, BD will start earlier in life, but patient will be treated later in life. So it's probably a link between childhood trauma and the clinical outcomes, because this duration of untreated bipolar disorder has been repeatedly associated with poor outcome in BD. So starting earlier means a more severe and complex phenotype, but being treated with a longer duration means also developing probably a more severe complex disorder. And the last penalty that is associated with childhood maltreatment in BD is the fact that those individuals who have been exposed to such early life stressors probably do not respond fully to mood stabilizer. We do not have at the moment so many studies published so far, but there are 3 convergent studies, one from our group, one from Turkey, and one being recently published from Italy, I think, which describe the fact that when the patients have been exposed to trauma, they are less likely to respond to lithium. So on this slide, you can see that when the level of trauma is increasing, this is on the horizontal axis, you can see that the level of non-responders in black is increasing, while the level of excellent responders in white is decreasing. So it means that being exposed to trauma would lead to a more severe form of bipolar disorder, but also a form of bipolar disorder that may less likely to respond to lithium or maybe to other mood stabilizer, but at the moment we don't exactly know. We also now have very few data about the fact that childhood maltreatment can lead to or be associated to a poor physical health in BD. We have very few studies, and one is from the group from Georgina Ozang and Ellen Fisher in the IOP, showing that when the level of maltreatment is increasing, the level of associated medical condition increase in patients with bipolar disorder. And as you can see on this slide, when the level of medical illness is more than 2, the level of reported childhood abuse or neglect is much higher as compared to those who have no associated medical illnesses. So we have tried to replicate this result in the FACE-BD sample, which is for this extraction composed of more than 1,500 individuals with BD, with a majority of women with a median age around 40. All assessed with the CTQ and for a checklist of more than 30 possible associated medical disorder. And we used the sum of the medical disorders that are present at baseline to try to estimate a medical burden in each individual. Most of the individuals have at least 2 medical comorbidities, the most frequent being those related to the metabolic syndrome, meaning problem in cholesterol, in lipids, in hypertension, in blood pressure, but also these samples describe more migraine, headache, allergies, and head injury, for example. And when we look at the medical burden, so the number of associated medical conditions in this sample, we can see that when the number of childhood trauma is increasing from 0 to 5 different subtypes of trauma, meaning neglect plus abuse in emotional, physical, and sexual domain of assessment, there is an increase of the number of medical comorbidity, this number of medical comorbidity being highest in the subsample of patients who report having 5 different subtypes of trauma. And when we try to disentangle the different contributors to this medical burden, we have that obviously medical comorbidities are increasing with age, with the number of treatment, with the level of depressive symptoms, but also with childhood trauma, more specifically with emotional abuse and sexual abuse. Interestingly, regarding medication, only lithium use is decreasing the level of medical comorbidity in this sample. We then re-extract more specifically this database to have a focus on childhood trauma and metabolic syndrome in BD. So this sample is near to 3,000 individuals with BD1 and BD2 mainly, assessed with the CTQ and with the different component of the metabolic syndrome being assessed at the physical exam at baseline. And as you can see on this correlogram, there is virtually no strong correlation between the different subtype of trauma and the different component of metabolic health. So inversely to our hypothesis, it doesn't seem that childhood trauma specifically increase the medical burden in terms of metabolic health, but probably is a more broad increase of the medical burden and not specifically around the metabolic syndrome. I will then move to another part of my talk, which is how early life stress and childhood maltreatment interact with the genetic background to increase the risk of developing bipolar disorder or to modify the clinical expression of bipolar disorder. And I will just make a focus on this 2-hit developmental model of vulnerabilities that has been proposed by Mary Cannon. And I like this model because it postulates that there are some interaction between very early life stressors, including pre or perinatal factors with a genetic background to create like a priming effect, so meaning leading to very subtle change in cognition, brain structure or connectivity, or the level of biomarkers in the blood, for example, leading to subtle preclinical symptoms. And then the individual with this kind of symptoms will experience later stressors that can be, for example, being exposed to cannabis during adolescence, and this may increase then the risk to develop psychosis or affective disorders, or to be resilient if some resilient factors are activated. And this is one model that incorporates the notion of gene-environment interaction in psychiatry. And you, by definition, all knows this very famous publication of Caspi in Science several years ago, showing that when the level of severe maltreatment is increasing, the probability of major depressive episode in the adulthood is increased, mainly in those having the short version of the serotonin transporter genes. So it means that in gene environment interaction, the effect of the E factors on the phenotypes depends on the genotype of the individual. So this is like a moderation, in fact. And in bipolar disorder, we have only a few data about GE interaction, mainly on the age at onset of bipolar disorder. For example, this study is about the interaction between sexual abuse and BDNF valine methionine variant on the age at onset in bipolar disorder. And when the individual are carriers of the methionine allele of the BDNF gene, and in presence of sexual abuse, there is a by 8 years decrease of the age at onset of BD. But such an effect is not seen in those who are non-met allele carriers of the BDNF gene. So it means that there is an interaction between BDNF, sexual abuse, and the age at onset of BD. We have looked at similar data, but looking at the interaction between CTQ, the long-short variant of the serotonin transporter gene, and here again the age at onset of bipolar disorder. And as you can see, the effect of CTQ and the effect of the number of trauma on the age at onset in BD is seen mainly in those who are carrying the short version of the serotonin transporter gene. So it means here again that there is probably an interaction between CTQ and especially the number of trauma, 5-HTT-LPR, on the age at onset of BD. So this is just a few examples of GE interaction on the age at onset of bipolar disorder. Now we are not focusing on specific variants within specific candidate genes, but we can rely on the polygenic risk score for bipolar disorder in interaction with the CTQ on the risk of developing a more severe or an earlier phenotype of bipolar disorder. So with our colleagues in Norway, we have used a sample of patients with bipolar disorder, all assessed with the CTQ and for several clinical outcomes, and all of them being assigned to a bipolar polygenic risk score being calculated from the data of the PGC. And we have not found so many interactions between CTQ, polygenic risk score for BD, and the clinical outcomes of BD. In fact, the only interaction I would say we found was between CTQ and PRS on the probability of having rapid cycling, but which was not in the good direction, I would say, because those with rapid cycling have high CTQ or low PRS, or high PRS and low CTQ. So it means that this is not the interaction we expected to find. And there is now a much larger study published by the team of John Kelso in a sample of more than 1,000 individuals with BD, assessed with the childhood life events scales, and all being assigned a polygenic risk score for BD. And they find only one interaction, which is the fact that more childhood trauma and higher polygenic risk score were independently and interactively associated with an earlier age at onset of BD. So at the moment we have more example of GE interaction when using very specific variant in very specific candidate gene as compared to when you're looking at the whole genetic risk as with the polygenic risk score for bipolar disorder. Another issue that is very important in this field of the role of CTQ or childhood trauma in bipolar disorder is the fact that we have all this clinical data with a more severe phenotype, less responsive to treatment. We have probably some genetic moderators. But what we would like to find for the next future is to identify clinical and molecular mediators. And when we are looking in clinical and molecular mediators, we are trying to find some clinical variables that mediate the links between childhood maltreatment and the outcomes in BD. And if we find some clinical mediators, it can be very relevant to identify clinical targets. So meaning targets we can use for how we care, how we manage, how we provide specific intervention for these traumatized people. And if we are identifying some molecular mediators, meaning the links between childhood maltreatment and the clinical outcomes in BD, it means that if we have some molecular mediators, we can imagine to develop some new targets that can be very relevant to treat patients with bipolar disorders. So when we are looking at some clinical mediators, it means that we would like to identify some clinical dimension of some dimension of psychopathology that can mediate the links between childhood maltreatment and the clinical outcomes in BD. And this is just a few examples of some clinical mediators we can explore, such as, for example, cognition, delusion proneness, but I will mainly focus on affective regulation and hostility and impulsivity. Still with our colleagues in Norway, we have tried to provide models for the links between childhood trauma, several clinical outcomes in bipolar disorders, and affective lability. Affective lability is measured here by the affective lability scale, which is measuring the trait proneness of an individual to rapidly shift from anger to elation, from anxiety to depression, and so on. And we find that there are some mediation models we can provide for several outcomes. And for example, emotional abuse increase the level of affective lability in the anger subscale that in turn increase the risk for suicide attempt. And the links between emotional abuse and suicide attempt are fully mediated by emotional lability in the anger subdimension. We find very similar result when looking at anxiety disorder, and the link between emotional abuse and anxiety disorders are mediating by the affect lability for the anxiety depression subdimension. So this is an example of how some affective lability dimension can mediate the links between emotional abuse and several clinical outcomes in bipolar disorder. In the FACE-BD sample, we have tried to provide a more comprehensive model. So on the left, you have EA, which is emotional abuse, physical abuse, sexual abuse. We have in the middle several dimensions, which are affect instability, affective lability, hostility, emotional hostility, motor hostility, and impulsivity. And on the right part, you have the different outcomes we have explored. So suicide attempt, rapid cycling, onset polarity, substance misuse, and age at onset. And as you can see first, all the dimensions are increased by the presence of emotional abuse, whereas physical abuse and sexual abuse probably contributed to a lesser extent. And we have then two paths, meaning that there is a first way from emotional abuse through mainly affective dimension to suicide attempt mainly, whereas there is a second way from emotional abuse to motor hostility and impulsivity, mainly to substance misuse and a little bit to suicide attempts. So this is another way to indicate that this affective dimension or this impulsive hostile dimension can mediate the links between childhood trauma and the clinical outcomes in BD. And this result has been replicated very recently by the team of Stephen Marwaha in the University of Birmingham with in a larger sample of patients with only bipolar 1 disorder and two scale, the affective lability scale short form and the Barat impulsiveness scale, and different assessment of childhood life events. And here again, it has been shown that there are some links between childhood abuse and the clinical outcomes in BD that were mediated by affective instability and impulsivity. As you can show, there is a first path from childhood abuse to affective instability and mainly to rapid cycling, number of depression and mania per year of evolution, age at onset. And there is a second path going from childhood abuse to impulsivity and leading to an increased risk of rapid cycling, suicidal behavior, and substance misuse. So at this step, it means that we can identify some clinical mediators that can be affect lability, impulsivity, that in turn can be postulated to lead to a lower emotional daily regulation, greater sensitivity to stressor, less impulsive control, substance misuse, and leading to early age at onset, relapse, staging, and suicide attempt, for example. And what is interesting is that the fact that affect lability and impulsivity might be targeted by specific psychosocial or psychotherapeutical interventions such as trauma-focused CBT, EMDR, or different type of therapies such as acceptance and commitment or dialectical behavioral therapy. But in this field at the moment, we do not have really a lot of information about the effectiveness of such intervention on the clinical target and then on the evolution or the course of bipolar disorder. For example, there is this very recent published narrative review from the group of Paolo Brambilla in Italy about the role of EMDR on trauma in affective disorder. And you can see that there is only 3 studies in BD, a little bit more with 12 studies of major depressive disorders, but suggesting that EMDR might be an effective tool in reducing trauma-related symptoms, so for example, affective lability, impulsivity, but also having an impact on the outcome of BD with a lower rates of manic and depressive symptoms. So if we identify more clinical mediators, we can identify more clinical targets and provide more intervention for those very vulnerable individuals who have been exposed to childhood trauma. So we have seen that there is probably some clinical mediators between the links between childhood maltreatment and clinical outcomes in BD. But we can try to identify also some molecular mediators, meaning abnormalities in the blood or in the brain that can link the exposure to childhood maltreatment to the clinical outcomes in BD. And when we think about potential molecular mediators, there are some obvious examples that come to mind. First, modification of the HPA axis can make the links between childhood trauma and the clinical outcomes, but there are some other usual suspects, such as the neurotransmission, abnormalities in some immune inflammatory markers, some abnormalities in neuroplasticity or oxidative stress. This slide is showing you an example about how childhood trauma can modify the levels of expression of several genes in the HPA axis. This is a study that has been published by one of my PhD students, Diane Griot-Laroche, and she has used the blood samples of 40 patients with bipolar disorder to measure the level of expression of 9 HPA axis genes in the blood, and all this sample has been assessed with the CTQ. So she used PCR for 9 HPA axis in green and 3 reference genes in orange, and she used this data to build the network of co-expressed genes in the HPA axis in presence of childhood trauma. There is a first condition that is presented on the left part of the slide, which is the CTQ total score. And as you can see, with this condition, the level of co-expression of gene is not modified, meaning that all the genes are linked together and being co-expressed with the other genes in the HPA axis. In the right part of the slide, you can see a condition that modified the network of co-expression. So when the patient has been exposed to emotional abuse, there are 2 genes that behave very differently as compared to the rest of the network, and these 2 genes, which one is the glucocorticoid genes, in presence of emotional abuse are not covariating with the rest of the network. So it means that when people have been exposed to emotional abuse, they have a differential level of expression of some genes in the HPA axis, meaning that emotional abuse can lead to the modifier of the expression of these 2 genes. And when we look at gene expression, we look by definition at gene expression regulation, which is mainly linked to what is so-called epigenetics mechanism. And this epigenetic mechanism are subtle changes in the DNA structure, but not in the DNA sequence. So it means that, for example, the level of histone acetylation, the level of DNA methylation is a way to fine-tune the level of expression of the gene and to modify the gene expression, and then probably the level of expression of traduction of the protein and the clinical outcomes in BD, if we can imagine this so far. And for example, when we look at some epigenetic association between DNA methylation and CTQ, for example, we find some study in mood disorders and personality disorder, finding that when the level of trauma is increasing, the level of methylation of the glucocorticoid receptor gene, which is one being enlightened in the network analysis by Diane, is modified. So it means that in presence of childhood maltreatment, the methylation of this gene is increasing, meaning that probably the level of expression is decreasing. So we have this fine-tuned way to adapt the gene expression through DNA methylation in response to childhood maltreatment. And we have in the general population, in PTSD population or in psychosis population, quite a lot of methylation studies showing that when people have been exposed to major stressors in life, including childhood maltreatment, it creates like a DNA methylation chaos in the genome. And just to mention this study in a non-clinical sample, showing that when you perform an epigenome-wide association study in association with childhood trauma in the general population, you find different genes that seems to be differentially methylated in presence, for example, of physical abuse or sexual abuse. And when you try to gather all the information of the biological pathway these genes belong to, the authors here have identified that the most differentially methylated pathway are probably those involved in the regulation of the nervous system development, the neurological system process, the neurogenesis, the glial cell proliferation, and so on. So it means that here again on the general population, this is made on blood, it means that the pathways that are highly modified in terms of DNA methylation by childhood trauma are those involved in the brain connectivity, the brain neurodevelopment, and so on. And I would like just to mention this very recently published systematic review about the association between childhood maltreatment and DNA methylation, and flagging all the different candidate genes and epigenome-wide approaches that has been published so far. And here again you can find that DNA methylation is probably modified in presence of childhood maltreatment in several biological systems. So meaning here again the HP axis, the neurotransmission, the inflammation, the apoptosis, the pathway involved in metabolic health, and so on. So all these pathways are possibly molecular mediators in the links between childhood trauma and the clinical outcomes in BD. Another probably very important clinical molecular mediator, is probably BDNF. And this is just here to mention the study by my colleagues in Norway in individuals with schizophrenia, bipolar disorder, and healthy control, with measures of BDNF in plasma and assessment with the CTQ. And as you can see on the graph, when the level of CTQ is increasing, the plasma level of BDNF is decreasing in the blood. So it means that even in the blood, it's possible to detect some association between the exposure to childhood trauma and probably a lower ability of the individual to have a proper or an accurate neuroplasticity system, as measured here only with the BDNF. And this makes nicely the links between BDNF and brain connectivity, because if we suspect that these individuals exposed to childhood trauma have lower ability to have a very neuroplastic system in the brain, it means that we should be able to identify some abnormalities in brain structures or in brain connectivity when they have been exposed to childhood trauma. And this is just an example of a study we have published several years ago in the patient with BD and healthy control using multimodal MRI and assessment with the CTQ. And what was observed in this study is that when the level of trauma is increasing, the lower is the amygdala volume, the lower is the prefrontal limbic functional connectivity, and the lower is the eusinate fractional anisotropy. So it means that childhood trauma can have probably very long-term effect on some brain volumes, especially here in the amygdala, but probably on the connectivity between different parts of the brain. So it means that here again, this is potential molecular or neuroimaging mediators that can make the links between childhood trauma and BD. And the last one are those who are related to immune inflammation, because here again there is a very dense literature about the fact that childhood trauma is associated with abnormalities in immune inflammatory pathway in adulthood. And there are at least 2 meta-analyses showing that in adulthood, when exposed to childhood maltreatment, individuals have abnormal level, for example, in CRP, several level of interleukin, or for example, in the level of TNF alpha. So this childhood trauma might increase what is so-called low-grade chronic inflammation. That is probably another way to have a target as a molecular mediator. And the last study I would like to mention, because this is also a very recent study published this year, I guess, which is from the Netherlands, and showing the level of association between different markers of the biological clock in somatic and mental health. And they identify different level of biological clock markers. So for example, telomere length, epigenetic aging, transcriptomic, proteomic, or metabolomic aging, and showing here that these different markers can be modified by childhood trauma. And this is more the case for epigenetic age, which is the methylation age of your genome, I would say, which show that those individuals with childhood trauma have an accelerated aging in terms of DNA methylation. So here again, this is another molecular mediator. So in summary, we have probably quite a lot of molecular mediators that can be seen at the level of gene expression, DNA methylation, blood or brain markers, or marker of accelerated aging, that modify a lot of biological pathway, leading to more sensitivity to stressor for the HPA axis, abnormalities in brain connectivity, for those with lower BDNF level and the high-grade chronic inflammatory markers. Also, it can make the links between childhood trauma and medical burden when we are looking at these immune inflammatory markers of accelerated aging. And it can also modify the response to drugs. For example, if one pathway is specifically targeted by lithium, CTQ may modify this pathway, rendering lithium less effective. And these drug targets are very important to identify because they can be a new avenue for developing a new treatment. And if we identify some pathway, we can, for example, use some drug repurposing approaches to identify drugs that can reverse the molecular scars linked to CTQ. We can also use drugs that target specific pathways, such as inflammatory drugs or senolytic drugs, for example, if we would like to reverse the phenotype of cellular aging. And in this domain, we do not have so many data for that, but I just want to highlight this clinical trial of infliximab, which is a chimeric monoclonal antibody used in autoimmune diseases that has been used as an adjunctive treatment versus placebo in bipolar depression. And the slide is probably a little bit too small, but there is a response to infliximab specifically in the subsample of those with bipolar disorder plus physical abuse. So it means that probably one anti-inflammatory disease might be effective in treating depression in those being exposed to, for example, here, physical abuse. So I would like to end with a short list of take-home messages, and the first one is for clinicians. I am a clinician. I'm receiving each week several numbers of patients with bipolar disorders. So this is very important as clinician to be convinced by the fact that childhood maltreatment is frequent and severe in patients with bipolar disorder. Childhood trauma is associated with a more severe, a more unstable clinical expression of the disorder, but also with a poor physical health. So it means that this childhood trauma or childhood maltreatment, but also later stressors, by definition, should be part of the systematic clinical assessment in individual with BD. And for example, in the network of centers for BD in France, we are assessing all the patients with the CTQ when they arrive to the network. And this assessment should be very important and much more important in those individuals with severe course or high level of comorbidity. The second take-home message is the fact that we can identify clinical mediators of the links between childhood trauma and the outcomes of BD. And probably affective instability, impulsivity, or substance use are very potential, important, and relevant mediators. And they can be targeted by some focused or specific psychosocial intervention. However, today, the level of evidence for the efficacy of such intervention, I don't know, trauma-focused CBT, EMDR, and so on, remain weak when we are looking specifically to data in BD, because these data are mainly extrapolated from the data from PTSD. But their use should be considered at some point of the pathway of care, and their use need to be codified specifically in this condition of bipolar disorder. And my last take-home message will be that molecular mediators can be identified between the links between CT and the outcomes of BD. And these mediators at the molecular level can be abnormalities in gene expression, methylation in different pathways, biological pathway. And they might be considered as future targets for future drug development. This will help to move to something that is called a more personalized, a more stratified psychiatry based on CTQ and potential molecular mediators. I will just want to finish on a positive note, because we are talking about trauma, we are talking about severe unstable outcome, but when there is trauma, by definition, there is resilience. And I focus my talk mainly on trauma and vulnerability, but we all know that some of our patients have really been exposed to very severe maltreatment. They have developed bipolar disorder, but in fact, with some treatment, with some psychosocial intervention, they can cope very well with the disorder in their daily life. So when there is trauma, there is resilience, and we can work with this on in the patient to activate also some factors that can lead our patient to a better resilient state. And I just mentioned this very well-written review on the complex neurobiology of resilience after childhood maltreatment. I will end by thanking some of my research funding, with a special thanks to my colleagues in Oslo, so in the University of Oslo, and a special thanks to Professor Alan Jung in the IOPPN. And I would like to thank you for your attention.
You're on mute.
the French language these days as well. So apologies for that. Je vous en prie. Just to say thank you very much, Bruno, and we've got a few minutes for questions. One question that comes up time and time again is about assessing early trauma in someone who's currently depressed and retrospective bias in terms of the way we look at the past. I wonder if you could address that, because I know you've considered this very carefully.
Yeah, it's true that when we are trying to assess childhood trauma retrospectively, by definition, is one patient is mildly or severely depressed at the time of assessment, the patient can maximize, I would say, the level of exposure. So we are very carefully, when we are trying to assess this kind of exposure, to be in patients who are stabilized, who have very low level of depressive symptoms, in order to decrease the level of bias. And for example, if we are doing so in the population of bipolar disorder with the CTQ assessment plus a measure of depressive symptoms, if the patients are during normothemia or euthymic states, there is no correlation between the level of exposure and the residual depressive symptoms. So my recommendation is, indeed, if we try to assess this kind of exposure, we have to do so in patients who are stabilized with a low level of residual depressive symptoms.
Yeah. And I mean, I think one of the answers I always have to this question is that there's a paper from the famous Newcastle 1000 study published by Izzy Colvin and colleagues. First author was Sadowski, British Journal of Psychiatry, a few decades ago. And they looked at a prospective cohort who had childhood trauma evaluated very globally on a 6-point scale by health visitors. And this was, very quite crude, but people in the top half of the scale, and this was things like poor housing, parental unemployment and so on. People in the top half of the scale compared to the bottom in terms of childhood trauma had rates of depression at 35 that were about 7 or 8 times the group with lower adversity. So it's clearly an important factor. Well, we've got time for just a few more questions, Bruno. The relationship of childhood trauma to personality variables and long-term traits, especially things like emotionally unstable personality disorder.
Yeah. I know this is something we have very frequently in the clinics, because most of the time a patient or with bipolar disorder plus trauma resembles quite a lot to a patient with borderline personality disorders. So it means more instability in terms of affect on the daily basis, more impulsivity, more suicide attempts, more comorbid with substance use disorder, and so on. So it's very difficult to disentangle what is the difference in the context of childhood trauma between a very unstable, complex, severe bipolar disorder and a borderline personality. We have tried to do that because in the center, most of the time we are assessing mainly Axis 1, DSM-4 disorders, but we are also using, for example, the SCID-2 to assess borderline personality. And what we get in this type of clinical assessment is that most of the time we have borderline personality traits in this patient, but that do not fulfill all the criteria for bipolar for borderline personality. So I know that the boundaries between BD plus CTQ and borderline personality is very frequent and very I would say unstable, and most of the time we have this impossibility to definitively conclude if the patient has CTQ plus childhood trauma plus very unstable and severe BD or borderline personality. And we are combining in most cases for the care management, mood stabilizer plus CBT focused on trauma or emotional regulation strategy. So we have like an integrated pathway of care with psychoeducation plus mood stabilizer, but also using some techniques that are more oftenly dedicated to borderline personality.
Thank you, Bruno. There's a question which I might answer very briefly about the relationship between mood states and mood traits like affective lability and impulsivity and the big five, neuroticism. This comes from a personality researcher. It's very nice to see there's still personality researchers out there. Myself and Adam Perkins and a few colleagues from King's just published a paper where we looked at the relationship between extroversion, neuroticism, and measures like the MDQ and depression scales and so on. There's a clear-cut relationship between neuroticism and depression, less so between extroversion and hypomania, which was quite surprising. But emotional lability seems to be a long-term trait associated with bipolar disorder. So in the last couple of minutes, Bruno, there's a big question really about whether we can intervene in childhood to sort of compensate for some of these deleterious effects. So we hear a lot about childhood trauma. You've talked about resilience factors. But are there sort of social or psychosocial interventions that we should be doing for young plastic brains, people in the first decade of life that might help future mental health? It's a big question, but I just wonder what your thoughts are.
Oh yeah. Yeah, this is really a big question, but I think that we have probably an effort to put, I would say perhaps specifically in France. I will not talk for other countries, but we have probably an emphasis to put on those children and adolescents who have been exposed to trauma to organize their follow-up, because in most of the cases in France, when children or adolescents are identified as being exposed to trauma, most of the time they are going to a pathway which is more, in France we call a social sanitary pathway, which is mainly extracting the children from their families. This is within family violence and so on. But most of the cases are not really taken into account in the psychiatric care, and especially in the child and adolescent psychiatry. So this is mainly based on extracting people from the violent environment, but not providing care. So we are working quite a lot within what is called the Center for Trauma in France in order to better organize a pathway of care and follow-up of this individual who have been exposed very early in life to some traumatic events. And as you probably know, in France, child and adolescent psychiatry is still very
developing,
with a psychoanalytic view of child development and so on. So, for example, providing approach in terms of CBT, prevention of consequence of trauma, prevention of substance misuse in this very vulnerable population, and for example, EMDR approaches and so on is still very, very weak in France. So in the Center for Psychotrauma in France, they are trying to identify better links between child and adolescent psychiatry and also adult psychiatry in order to provide a pathway of care for these individuals. But at the moment, there is nothing really organized, and this is a shame to have nothing really organized in France. And another way to think is about to have this new drug repurposing strategy to say how we can reverse some molecular consequences of the exposure to childhood trauma. There are a nice review being published this year or in 2020 about a new drug strategy for preventing the development of PTSD. So this is another, PTSD is not childhood trauma, but there are some hypotheses about some treatment that can really be used to reverse, for example, some epigenetic scars after the exposure to trauma. And can this be used for very early in children? Maybe not, but in adolescent. But we can think that in the future we can have some drug targets that can reverse the molecular sequelae of this exposure. For example, we have a project about the exposure. So this is a very kind of exposure to trauma. This is the families who have been exposed to ICU environment because some member of the family has been hospitalized in ICU. And the families of people who have been exposed to ICU environment develop a huge rate of PTSD symptoms. And we are trying to look at the molecular level to predict those who will develop this kind of symptoms and maybe to have some drug repurposing technique for preventing the development of this PTSD linked to the exposure to ICU environment. But at the moment, there are two repurposed drugs that are postulated at the moment to be probably interesting, but these are mainly for PTSD, and PTSD is what we call simple trauma, so mainly major, unique, whereas childhood maltreatment is something more repetitive, more chronic, which is probably not the same way to think about the molecular consequences. So this is like acute stress versus unpredictable chronic mild stress, which is probably not exactly the same molecular determinants.
Thank you very much, Bruno. Yes, it's worthwhile noting that one of the few drugs we have in psychiatry which has epigenetic effects clearly is valproate, which of course is a French drug, and we published work showing it can have measurable, modifiable effects on brain function. So perhaps we should talk about that. But for now, we could have an entire symposium on this. Thank you very much for your expert overview.